Hello and welcome to Life Unrestricted. I'm your host, Dr. Al Cobb. I'm a board-certified chiropractor and concussion rehab enthusiast in Lubbock, Texas. This podcast is devoted to helping you explore life and health in all of its many facets so that you can live a life that's truly unrestricted. Hey everybody, thank you again for listening to the next episode in this concussion series. If you missed the episode with Dr. Brooks Schisler, you are going to regret it. I hope you go back and listen to it as part one of our concussion series for the month of March, which is Brain Injury Awareness Month. To continue the conversation with me today, I have Melissa Biscardi. She's a registered nurse, manual osteopath, and soon-to-be PhD, whose clinical practice and research focuses on adults post-concussion. Melissa's PhD work is the first randomized controlled trial to study oculomotor rehabilitation using novel virtual reality technology and phone-based applications. She's the creator of an app called Brain Toolkit, which she uses for assessment and rehabilitation of concussion and in her research. Melissa has been trained by the Carrick Institute, which if you are a chiropractor or a chiropractic student, you will know that term. And she uses the applied neurology that she's learned there and an evidence-based approach to support the best outcomes in the clinic. She has a strong interest in rehabilitation-based interventions to help individuals with persistent symptoms recover and regain their quality of life. She's also interested in sex-based differences in concussion risk, subtype, and rehabilitation strategies and outcomes, which are all things that we're going to discuss today. When not filling her brain with neurofacts, she loves extreme hiking, her three-legged cat, which we're going to meet soon, and spending time with her younger brothers. Thank you for listening, and I hope that you enjoy this episode. All right. Well, thank you so much for tuning in. Today I've got was that a cat?
My cat.
Heck
Yeah,
yeah.
my cat. I'm sorry. She
The
didn't
moment
meow
we
all
start
day.
recording, she's
Okay.
like, let me get on here.
Literally, she hasn't meowed.
She knew it was recording. You're good. This will be good. This will be good content.
She's fat, but she only has 3 legs. She's missing one of her back legs.
That is so good.
She's a little rescue. She looks angry, but she's very friendly.
She's happy. Happy cat.
There we go.
Awesome. Well, today I've got Melissa. She is going to talk with us through a little bit of her journey of concussion, clinical research, clinical education, and then the future of what she's got going on, and some great information that she's put together in an app for clinicians and for patients. So, Melissa, thank you so much for coming on today.
Thank you for having me. I'm excited to have this chat.
Absolutely. I am too. I've been following you on Instagram for a while, which listeners, if you do not follow her, I'll put it down in the show notes, but an amazing follow. If you're looking for education or support or hope, it's a great follow to be able to have someone in your corner giving you some really good information. But Melissa, I'd love for you to start off by just giving us a little information about why concussion. You're trained as a registered nurse, and you've done some osteopathic manipulation training, and you've started this journey to become a PhD. Give me a little information. Why concussion?
For sure. Yeah, it's definitely been a windy road to end up here.
Mm-hmm.
I started as an RN, and I never worked in the hospital. I worked in reproductive medicine.
Okay.
Right away, I knew night shifts, they were not going to be for me.
Mm-hmm.
So I started there. Then I got a little disillusioned about how it's run, essentially. And I went into research, and eventually I met who became my mentor, and he is an osteopath, but he's like me. He's not traditional.
Mm-hmm.
And I thought he was a physio, never mind. And I applied to physio school because I thought I want to be like Daniel.
Mm-hmm.
And then I found out he was an osteo. So I applied to osteo school. Like, I'm going to be like this guy. He was already interested in the brain. This is like 2010.
Mm-hmm.
So that planted the seed. And then 2013, I had this whole journey where I was losing my memory, and it was happening over, I want to say, a year or more, a year and a half, progressively getting worse and worse. And I just got lost in the system, invisible injury, looking fine on the outside. And yeah, no one took me seriously. Even I would forget patients, forget people I knew for 10 years.
Mm.
And I was like, this is a little too early for like early onset
Mm-hmm.
cognitive decline. And I ended up figuring that out sort of on my own, but it got me hooked on the invisible injury
Mm.
and the brain. And that was 2013. So still concussion stuff was very sparse, right?
Right.
And then, oh, yes, I don't know if you know this, but I'm actually a black belt in Brazilian Jiu Jitsu,
All right.
right? So
Heck yeah.
head injuries were happening around me. I started to
You
treat
were you were dealing out head injuries as well.
right? Take this and then book an appointment with me. No.
I got to
Uh,
get into a dojo around here.
and then I did have a concussion of my own, but I was already deep. Like I was already interested in it.
Mm-hmm.
And sort of here I am. It really, so 2015, I decided my practice was only going to be concussion, but it took probably a couple years for that to happen. Just
Mm.
transitioning, people getting to know that that was my focus. Yeah. And I just keep, learning more because
Yeah.
there is infinite knowledge that we can gain and
Mm-hmm.
to help patients.
Yeah. Well, you talk about exactly what it is, the invisible injury. I talked last episode, which people should go back and listen to because it's super great about the the invisible injury. You can't put a finger on it. You can't put a Band-Aid on it. So you show up in your care provider's office, regardless of what practice they're running, and there's they look down on you or they don't believe you when they tell you things like, I'm 20 and I can't remember my own name, you know?
Yes.
I had a situation. I had a panic attack after I took a soccer ball to the head, thinking I could head it well, and ended up a week later having that panic attack. And then I depersonalized. I was like, I don't even know my own name right now. I don't know my own family. Like I know them, but they're not my family, right? So
That's scary.
I got passed around all over the place, and so I was like, I don't know. I got to figure this thing out. And that's eventually what led me into chiropractic. And I'm forever grateful because now I'm able to do the same things you're learning, like the learning how to take care of brain injuries, the true invisible injury, and in a way that's proper. I mean, what was it in your journey that was, I don't know, there's probably tons of puzzle pieces, but what were some of the big puzzle pieces when it came to helping you get your life back?
So what ended up happening is have had chronic sleep issues since I was a teenager,
Mm.
essentially, and they were getting progressively worse. And I started to, mind you, my diet was poor. Like there were reasons feeding
Hmm.
into it for sure, but
Oh yeah.
um, even as a clinician, we're not always
Oh yeah.
the best
Sometimes
patients.
the worst patients.
Yes. And so I started to take Benadryl to help with my sleep. And at first, I was just taking it, I don't know how often, but not very often. And then I was taking it more often. And then I just started to take it every night to, and it even wasn't helping me get good sleep, but it was better than without any sleep. But I was taking Sleep Ease. So in Canada, Benadryl, the chemical, is marketed under different labels, essentially.
Hmm.
And yes, so I was taking this over the counter sleep medication, thinking all was fine and dandy. And I was at the gym talking with someone about sleep randomly. And he says, did you see that study that shows Benadryl is associated with dementia?
Oh my gosh.
And I was like,
You're like, no, I hadn't come across that yet.
yes. Oh my gosh. So, anyways, I looked up this study. There are a few studies now. They're on the older population, but I don't care how old the people are. If you find an association, I'm going to
Hmm.
pay attention to it. And just which medications have been correlated with cognitive decline. So I had to, well, stop taking that, get my sleep in order. I started to eat better. That was a huge factor. I was just eating bagels and granola. My blood sugar was all over the place. So
Hmm.
it really was an overhaul of my lifestyle. And that's often the case with concussion, also,
Sure.
right?
Hmm.
And we're a collection of injuries
Yeah.
collection of lifestyles, and then something tips us over the edge,
Hmm.
and we have to put the pieces back.
Yeah. And unfortunately, it's because in the reverse of that, we have to do so many things in different fields of our bodies, I guess is the best way to different tanks in our bodies we have to address because concussions are a full body injury. We talk
Yeah,
about them, we hear about them as just brain injuries, but and that's what they are, but the cascading effects go far beyond. What have you seen with that?
absolutely. I love that saying as
Hmm.
well. Like it is a full body injury.
Hmm.
Even when we think of people who are hit in the head, like not even just hit in the shoulder and the forces go up, but hit right in the head, still the forces go all the way through the body.
Hmm.
And what was that day like for the person before the injury happened? Are they
Hmm.
going through a divorce, right? Did they just lose their job? So I think the emotional environment at the time of the injury definitely matters. So all
Hmm.
of those layers that need to be considered.
So you have your brain injury, your initial brain injury. And at that moment, you have an instant neuroinflammatory cascade
For sure.
and it depletes all of the energy in the brain. So then you've got a mental aspect.
Mm-hmm.
Along with that, within 2 to 4 hours, you have leaky gut. It's researched, it's out there. We know that it happens, and it happens for a reason. Usually it closes back up. If
Mm-hmm.
it continues to have some inflammation in the brain and the body, it's going to stay open. So then people have food allergies. Then
Yes.
people have digestive issues. And then there's hormonal issues. And it just
It's a
continues
vicious
on and
cycle.
on and on. It's a vicious cycle, like you said. Yeah.
And it's so funny because I was just talking about the gut brain axis, I think it was yesterday, and
Mm-hmm.
just how exactly that axis is disrupted within 2 to 4 hours. And then that being disrupted can cause more inflammation in the brain, which can
Mm-hmm.
cause more disruption in the gut,
Mm-hmm.
right? And that we need to pay attention to how we can support the gut in order to heal that. And
Yeah.
if someone already has systemic inflammation, so it really is like a full body approach that we have to take
Mm-hmm.
recovery.
And usually it takes a team, I've found. Have you
Mm,
seen that as well? You've got
absolutely.
to have, if it's one person that can do all these things, fine and dandy, but it's going to take probably a team. You're probably going to have people in different fields, a PT, a DC, um, a naturopathic doctor, your primary care, all these things going together, and communication becomes
Huge.
essential.
And I
Absolutely.
find a really important member of the team also is like psychotherapy
Mm,
here. That's delivered often by a social worker.
mm-hmm,
But the mental health aspect, it
mm-hmm,
just, I feel sleep and mental health, they will either make the recovery or break the recovery.
mm-hmm. I hear that. Man, well, I wanted to kind of dial in on one thing that you said, and it's something that I've actually had a lot of conversation with, and it's probably look hearing about your background as your RN journey, reproductive health. Is that why you're interested in the phenotypes, whether it being higher likelihood of women or higher statistics of women suffering concussion?
Let me see. So why do I love the phenotype so much? I love organization, definitely, because I think it helps people understand things
Mm-hmm.
and you can break it down into so many layers so we can
Mm-hmm.
simplify it to communicate to people who really know nothing about their body. I
Mm-hmm.
once was talking about the nervous system, and my patient said, "What is the nervous system? What are you talking about?" And I realized, wow, I just take things for granted. Can't make assumptions,
Mm-hmm.
right? And I do love the phenotypes for that, really allowing us to organize our thoughts.
Mm-hmm.
Uh,
And treatment protocols, I'm
yeah.
sure.
And with the hormonal aspect, I don't know if you know this, my master's thesis was actually on um, females with persistent symptoms and looking at this hormone, anti-Müllerian hormone, which is a predictor of fertility. My sample was really too small to say anything meaningful, but it really is interesting because women can have disruptions early on. Well, men can have hormone disruptions as well.
Sure. Yeah.
But early on, they can change over time. And if you don't ask about them, then the women will suffer in silence, essentially, and wonder, like, what the heck is going on with my body? That isn't really a phenotype, though, but it should be. Where does it fit? It fits in like the side.
Yeah.
The
Which
side box.
Unfortunately is how research is in women typically,
Yes.
unless it's a specific, what I've seen and what I've read, for the most part, most research is done on healthy middle-aged men.
Absolutely.
Unfortunately.
And it wasn't, when was it? I want to say in the 80s. Like, women were not allowed to participate in research for something like, I forget how many years it was. I did look this up. But what happened, let's say it was in the 30s, is there was research being done and it ended up harming women. And so they said, okay, we're just not going to do research on women anymore. Like, that makes sense, right? And
tons of sense.
So we were left out for so long and just treated as little men. But, men should not be treated as big women either.
Right.
Personalized medicine.
Yeah, personalized medicine is absolutely the true case. What I think, too, is part of the hormonal issue, especially with women. Well, what I've seen in the research in my training is twofold, I think. One is just the head to neck musculature ratio being much different in men and women, but also the hormonal aspect of each week of the cycle being different.
Yes.
And if you don't have a normal cycle, you're probably on some type of birth control, which is also a risk factor as well. Have you looked into that at all? Have you seen much research around that?
Yeah, absolutely. And I really like to speak to this as well, because in a woman, like a menstruating woman, we know that the really vulnerable time is the luteal phase, like right before a woman gets her period. You're at increased risk for sustaining a concussion. And also, if you sustain a concussion during that time, it's more likely that you'll have PCS or complicated recovery. But then we also know that just being a woman, you're more likely to have complicated recovery. So the layers add on to each other. If we track the cycle and we know the injury happened in that time, even just thinking about expectations for recovery, but where it's really powerful is when you're working with athletes and thinking about return to play. You're not going to return an athlete in their luteal phase, right? Like, that's actually something we can control, and we can control a lot when it comes to concussion. But I think that is something that just, it's a no-brainer, for lack of a better word.
Pun intended.
You have to, but any advantage that we can take against concussions, we should.
Absolutely. And again, it goes to this idea of personalized care. And it's something that people want more and more, probably more now than ever, especially since the pandemic happened. Then AI being able to tell you the answer to anything at any time. People want this specialized type of care. And yeah, I agree with you. I think it definitely is the future. I'm glad to know that there are people like you that are out there that are providing this type of personalization.
Thank you for one.
Yeah.
I once had a patient say to me, I know you've helped all these people, but can you help me? And that's really the bottom line. There is social proof, but the person in front of you needs hope that they can get their life back.
Right. Man, that is the absolute truth. Man, let's talk about a little bit of the concussion phenotypes.
Sure.
So it seems like this is like your jam,
I love
right?
it. I love the word phenotype. I think that's really what attracted me to it. I'm like, that is a cool word.
And so phenotype, for those listening, is the physical manifestation of some type of illness or gene expression It's what we actually see. It's the physical portion. That's the pH. That's how I always remember it.
Oh, yes.
So yeah. So Melissa, go ahead and tell us what are these phenotypes? What do we look for? What do we typically see in concussion patients?
Sure. So there are a number of different phenotypes or subtypes, and depending on the research, they'll be organized differently. There's
Mm-hmm.
not really a consensus on it, but often it's categorized as there's a cervicogenic or like a neck and tissue phenotype where we think a lot of the concussion experience is coming from there.
Mm-hmm.
There is the oculomotor vestibular phenotype. Sometimes they're separated, sometimes they're put together, but
Mm-hmm.
most of the symptoms or some are coming from disruptions in eye movements or in the vestibular system.
Mm-hmm.
There's autonomic, or I don't think it's called cardiovascular ever, but it could be, or the other way
Sure.
around.
Mm-hmm.
But that is like exercise intolerance.
Mm-hmm.
That would fall into that one. And also things like POTS, I think, are often put in
It
there.
would
So,
fall into that one.
right. And definitely there's one around mood. So anxiety, depression, even PTSD would
Mm-hmm.
fall in there.
The
Sleep,
psychological phenotype.
psychological, which is huge.
Mm-hmm.
And then sleep is thought of as a modifier sometimes or its own category, which again, as we were just saying,
Mm-hmm.
it plays a huge role in recovery. What's the other one? Why can't I remember?
Is it like endocrine or something?
I don't think it gets its own, to be honest. But you know what? I am going to make a post
Hey,
and I'm going to tag you that we are creating a new phenotype,
yes, the phenotype duo, neuroendocrine.
right?
I'm
Because
writing it down.
it's not there. So where do people think it fits in? I think it's a lost phenotype, which is crazy because
It's a huge one.
that's a huge influence, right?
Mm-hmm. Absolutely. Yeah, I have one patient I started working with, and so the interesting thing when we think about the endocrine system, the pituitary gland is like the master endocrine controller. There are other organs or glands in the body that do a lot, but the pituitary gland sits in this little fossa. And from an upper cervical chiropractic perspective, we're looking at areas where the spinal cord or neural tissue anchors in to the spine or the brain. And at that level, there's so many connective tissues. There's so many vascular components to that area too. There's a little bitty stalk kind of like sitting that connects the brain to the pituitary gland. And in the same way that an upper cervical ligament can be anchored into the tissue of the spinal cord at the upper cervical spine or the hole in the bottom of the brain, it still connects right there at the pituitary gland too. And there can be, if it's a really bad traumatic brain injury, there can be actual disruption there that causes
Mhm.
actually clinical hormone regulation issues. But if it's just a functional issue, I had one patient, he was hit in the back of the head by a bus window in Vegas. And I was like, what happens in Vegas, you know?
Right.
Um,
Did not
and
see in Vegas. It followed. Right.
right. And so he instantly, like, he has testosterone issues, he has
Mm,
stress issues, memory issues, and he's been in litigation for years with people because they're like, that didn't happen because of the head injury. I'm like, of course it happened because of a head injury.
right. Didn't happen on its own. Right.
Exactly. So I think it's extremely important, and it's what you're saying is the education component that people need to be aware of this stuff.
Mhm.
I even encounter it. You probably encounter it all the time with your background as well. But in my world, people have had a car accident and they've gone 10 or 20 miles an hour when they were hit or in the car accident. And what I've seen is they don't take into account the neck portion. The first one you mentioned, the cervicogenic one, starting in the neck. And if we can just adjust the neck, we'll adjust them one time and it's like, oh, I feel
So much
like
relief.
80% better. Like, yeah, of course. And it's interesting the interplay between the neck, the eyes, the
Mhm.
vestibular system, the autonomic nervous system as well. So sometimes it can be the easiest entry into the system to help these neurological structures start to rehab. And it's been fun. I work with vestibular therapists across town as well. We co-manage some cases, and I've seen if we're both working on the same patient, then it's like they're getting crazy good results.
Yes, I have an affinity to the cervicogenic phenotype for sure, coming from osteopathy.
Sure.
But also because of the connection with the oculomotor vestibular system. But as the autonomic nervous system, we were talking before we started recording about POTS, but how that the feedback from the receptors in the neck, if those are off, then the blood vessels might not respond quickly. And when you get up, you'll have lightheadedness. So I feel like we can just make so much progress when we clean up the neck.
Oh, yeah, absolutely.
That has ripple effects on the other phenotypes.
Absolutely. And, the brain has to communicate to the rest of the body some way. And the only highway to get there is through the neck. There you go. Hey, you would have been a great upper cervical chiropractor, Melissa.
That'll be my next degree.
There you go. We'll get you some type of equivalent, like a Canadian equivalent to that.
An honorary.
Yes, there you go. Man. Well, let's talk a little bit. You love ranting a little bit on Instagram, and it's my favorite thing to watch.
Good.
What? Talk a little bit about.
I rant in a friendly way, though. I feel like.
Yeah. Oh, yeah. Absolutely. It's an educating rant.
Energy. I try to make it fun.
Yes, exactly. To talk a little bit about the education piece. What is it that you're seeing that you mentioned the psychological component, and I think it's part of a larger topic of this biopsychosocial model of taking care of people, the life aspect, the mental aspect, and the community aspect, so that we're able to fully help these people recover. I think that the misinformation that we see, and I've commented on one of your posts recently. I said, this right here is why people have post-concussion syndrome. And it was the advice, don't do anything, just rest for 2 weeks and see what happens.
It's just
Talk
like
a little bit about
on your bum, right?
What'd you say?
It's just like a bruise on your bum.
Yes, that's exactly it.
And yes, it just baffles me how some clinicians have not gotten their knowledge up to date on concussions. Like if you're telling people to sit in the dark, you are so out of date. You're almost 20 years out of date, right? And it's not helpful. And I think it's very challenging and traumatic for patients because they're told one thing and then it actually makes them worse. Then they eventually, hopefully, find their way to another clinician who is maybe well versed and say, actually, that's not really what we do anymore. And there's a missed opportunity there for starting recovery early. It's crazy. We know early rehab results in better outcomes. This makes me furious when people are cocooning they'll call me, so I just stayed in my room for 4 weeks and now I'm ready for rehab. Oh, it's just terrible. So that's one reason why I'm passionate about it and getting the word out. My first little download, I should share that with your listeners. It's like Concussion 101. I made it in 2019 and I said, print this, put it in your what are they called? The medical kit, like put it in your first aid kit. You never know when a concussion is going to happen. This is what you're supposed to do.
Yeah.
People need to know ahead of time. After you get a concussion, the last thing you have energy for is searching for information and even filtering like what is right, what is not right, what is right for me.
Yeah, absolutely. And it's like you said, early education leads to early intervention. And it's crucial because the brain thrives on movement, information, and oxygen to be able to rehab and recover. And I think that a lot of exercise intolerance is probably a loose statement, but it's probably due to the fact that we just sit around and we don't get our bodies moving. and our heart pumping and the blood flowing to the brain and back down, which is a massive part of detoxing the brain, taking out those debris, taking out the
Yes.
trash of the brain. What have you seen in terms of early intervention when it comes to education? What is best when people have a concussion? What should they be doing?
Definitely, you can take it easy. Yeah, tell me if you disagree with any of this,
Yeah,
but
I got you.
in the first couple days, take it easy.
Mm-hmm.
In essentially relative rest. So you still don't have to cocoon the first couple days.
Mm-hmm.
You can even go for a walk, eat well, get a good night's sleep, like sleep at night when you're supposed to be sleeping. That's when you should be in your bed. We know that we don't need to wake people up every hour because then they're really going to hate you and feel like crap the next day, right? But keep an eye on them.
Mm-hmm.
And then at 48 hours, you can see your concussion clinician and
Mm-hmm.
even start early exercise, depending what else is going on with your body. But you can get moving in one way or another.
Mm-hmm.
And then we have guidelines. But if you don't have a guideline, you can start conversation paced walking, like get the blood flow going, even in terms of we know the brain has had a massive energy utilization like over the last 48 hours, and we need to get the blood, nutrients, oxygen
Mm-hmm.
to the brain, right?
Mm-hmm.
So the walking and eating well is huge. Some
Oh
people,
yeah.
and it surprises me, but some people have a hard time letting go of the alcohol while they're recovering. And that's like a
Mm-hmm.
really, that's gonna disrupt your recovery. So
Mm-hmm.
some of the low hanging fruit, right?
Mm-hmm.
And
And the
then
free stuff. That's free.
yeah, the free stuff, right? The
You
stuff you
save money
spend
actually
on
when you
our
don't drink as much.
Instagrams.
Yeah.
And then depending on, the individual, start to tailor it.
Mm-hmm. Yeah, I think that is I saw a study recently. It came out in the last several years. I can't remember, but it said the number one indicator of recovery time for concussions was intervention. How
Yes,
quickly did you get into a clinic to start active rehab?
I see
And
that like all
hmm
the time in my clinic.
hmm and I think that it's not. I don't think that I don't think it's good enough anymore to just pass the protocols. I think we've got to be looking at some of these neurological structures. We got to be looking at your eye movements. How are you understanding where you are in space? Does your balance look good? Do you have neck pain? Are you starting to have headaches? Is your posture changing depending on this recent accident you've had? You you've been up to some really good work developing an app called the Brain Toolkit, which I'll link down below for people to go grab. It's $15 and it is awesome. I think I would love for you to talk about how did this come about? Was it part of your research? Talk a little bit about where did this come from? Where did the idea come from? And why have you kind of formulated this?
When was it? Maybe 2019. I noticed that there was a huge gap in terms of helpful app that was for Android and Apple, for
Oh,
one. And I'm an Android user, so
oh
I know.
no.
And that was financially accessible. The
Mm-hmm.
There's only one other app that I would say is similar, and it's 4 times the price, right?
Yeah,
And
I think I
patients,
know the one you're talking about.
right? Yeah. So patients have limited money often.
Mm-hmm.
So I wanted to fill that gap. Believe it or not, before nursing, I did a couple of years of computer science,
All
computer
right.
programming. And so I guess that's somewhere deep in my hippocampus and pops up every once in a
Right.
while. And
And
so,
maybe some in the amygdala, I'm sure.
right, yeah. And so I was like, I'm going to make an app. And my brother, he's he's a computer programmer. He's way
Nice.
younger than me. So he's just graduating now. But I said, Mick, can we make this app? And when the first version was very basic and all it had was the first 4 items:
Mm-hmm.
gates, abilities, saccades, pursuits, OBK.
Mm-hmm.
And so he made it, played around with it. I asked clinicians for their feedback, and now this must be the fourth edition. So I keep adding to it. based on what I feel like I need in my practice. And then I'm always taking in feedback from clinicians or patients to
Mm-hmm.
make user friendly and helpful. And now I think it's just amazing. It covers so many aspects of assessment. You can be creative with interventions and also progressions. So
Yeah, that's
love.
awesome. So I'm looking at it right now.
Yeah.
You've got a couple of things that I think are amazing. There are the eye movements.
Yeah.
So being able to stabilize your eye movements, being able to move your eyes quickly, moving your eyes smoothly, which is what we call pursuits, and OPKs, which talk a little bit about those top four, the ones that were originally in there. Why
Absolutely.
are they in there?
So gaze stability, our ability to look at something and have that image stable
Mm-hmm.
on the retina, on the back of the eye. That's the most foundational thing our eyes need to be able to do. We
Mm-hmm.
take it for granted. And sometimes it can be disrupted, but our brain is just taking care of that noise for us.
Mm-hmm.
If that's happening, that is going to cause fatigue, headaches. Maybe you're not going to remember what you're reading. So
Mm-hmm.
that was the first one. And then if you don't have an app, we have people look at dots on the wall, right?
Mm-hmm.
Let's say we want the tech version, we want to be able to progress it. So that's why I put that one. The saccades, which are jump eye movements,
Mm-hmm.
we do 100,000 saccades a day. But
Mm-hmm.
again, it doesn't mean we're doing them well. So I wanted to have that in there. And both of those are disrupted after a concussion.
Mm-hmm.
And the smooth eye movement, the pursuit, like following a bird passing by you
Mm-hmm.
or a car, again, that's part of so there are the 6 eye movement systems,
Yep.
and that is one of them. And then OPK, as if a train is going by, our eyes
Mm-hmm.
are supposed to know what to do, and follow, reset, follow, reset. So just these really basic, but at the same time complex things that can be disrupted and that we take for granted. But if they're
Mm-hmm.
disrupted, it's really going to interfere with how you're feeling, even with simple tasks. So that's
Mm-hmm.
why I had them there as sort of the foundational four.
Yeah, absolutely. And they're the best because they're what people experience in real life. And we know based off of the research that the eyes are usually disrupted in some type of concussion event. And when you think about it, people come to me after, and these aren't athletes, these are people, these are adults who are working adults, and you've probably experienced this too. They go to the grocery store,
Mhm.
and when they walk down the aisles, they get extremely dizzy. And it's exactly what you said with the OPK. It's a very mild look. Not only are they moving their neck around and the vestibular system's moving, their eyes are also moving. They're integrating that, a bunch of information going in, lights
Mhm.
probably, but
Yes.
then there's just movement on either side, and their brain is not able to compartmentalize these things. And
Especially if there's an asymmetry in the deficit, which often there will be. So you're getting
hmm
good information, or maybe 80%
hmm
on
yeah,
one side, and you're scoring 50% on the quality on the other side. So
hmm
it's just like a cornucopia of
sure,
stuff you don't want.
yes, um, perfect grocery store reference there. And
Right?
also people who, when they drive, they either they
Yes.
have a panic attack while they drive, or they can't drive in wide open spaces, or they can't drive in narrow alleys with a lot of cars around them. And they still, same thing, get dizzy. And I think that people underestimate the impact of the eyes just as much as they do any other system or phenotype, because it's just something you think, oh, I don't need glasses, but
Yes.
the eyes are extremely tied into the brain, and very fine movement control, autonomic information. Even when you move your eyes around, the neck starts firing in the upper cervical spine. And so all these systems are so intricately interwoven. Um,
And
yeah.
also, as manual therapists, we make such a big difference with the tissue. But then I always say, okay, we have things moving, blood flow is going where it needs to go, but now we need some stimulation to
hmm
integrate it, right? We might treat the base of the head so we get those tissues that are attached to the eye movements, but now let's do some integration and really seal the deal on the recovery.
hmm One of the people that we know that talks a lot about this. I love this concept. Dr. John Chung, in upper cervical chiropractor, functional neurologist, He talks a lot about it's not like a hardware issue, it's a software issue, meaning that the integration of all these processes, it's not like there's a nerve out of whack. It's not like the eye is just broken and disconnected from the other parts. It's a processing issue a lot of times. And so I like to think of the like a concussion almost in the same way as if your computer randomly shuts down, if there's an outage or a short, then you've got to take some time to reboot it. You've got to find the processes that start to actively rehab the areas so that everything can start to integrate well. It's an integrative or dynamic integrative issue that we've got to start helping people be able to get back on track with.
Absolutely. And even I find, and I'm sure you find this too, there's an opportunity to even be better than you were before you were injured, right? And
Absolutely.
there's an opportunity to work on posture. And maybe I definitely recommend people cut the gluten early
Mm,
on. That's a big needle mover.
sure.
And often people will keep at least the gluten low, like you feel better. So I
Hmm.
do think in the trauma, there's also opportunity.
Hmm. And I think yeah, that's a great word because we think that trauma is going to set us back even more, and maybe we'll get a little bit better. But I think you're right. You learn things along the journey that make you extremely improved from before, even if you don't symptomatically feel it. The
Mhm.
things that you know, and the things that you've experienced, and maybe the hope or passion that you have for something is on a whole nother level now. Speaking of just improving, I've been using your app just because like I want to get better at some of these things. So when it comes to the memory or the recall or
Oh,
some
yes.
of the matches or some of those things that are involved in there, I've been using it just like on my downtime instead
Yes.
of like scrolling on my phone, giving myself the vertical OPKs on
Yes.
my timeline. I've been
And you can
using
compete
it.
with yourself too, right?
Yeah.
The
Uh-huh.
precedents does kind of score you.
Yeah, I was doing the Stroop test earlier, which is like always my worst test because I'm like, no, that's green. Oh, the word is green, but it's red. It just kills me. Anyways,
Are you getting better or no?
I'm getting better.
You should do some saccades before you do it. No, do some anti-saccades before you do it. So,
Okay,
right, when it blinks, look to the other one, and
okay,
then you're working that inhibition. And I wonder if that would help you
all
draw on
right,
the inhibition in the Stroop. Let me know.
yeah, all
I'll send
right.
you a bill.
Send me, yeah, just send me the bill. This is you tricked me into a telehealth. So give me an idea of what the future looks like for you. What's your PhD in, and what is your future look like?
Yes, so I'm knock on wood. I should be defending in December. So, sort of wrapping up my PhD, which is focused on interventions in adults post concussion. And
Hmm.
specifically, we're doing an eye movement intervention. I don't want to call it a protocol because it is individualized, but there's a loose guideline, and
Hmm.
my app is involved. And also, weekly interventions on VR goggles, essentially. There's a lot of stimulus in this intervention. And then the homework is on the app. People have been tolerating it well, though. People want to
Hmm.
get better. And so that will come to an end. I do not want to be a research scientist. Like, I love treating people, but I
Hmm.
want to put my hand in there. And I think it's good for the research world to have people who
Are
are on
taking care of people,
that.
the clinical researchers.
So I hope to have that sort of balance. And I don't really see my life changing too much in the immediate future. Like, I want to see patients,
Hmm.
maybe promote the app a little bit more widely outside of
Hmm.
my network, because I think it's a great little tool.
Hmm.
And yeah, and then just hopefully help others do some meaningful research.
I love that. I think that it's important to have people like you said um, who are in the actual clinic taking care of people, because one of the biggest qualms that I have with the science based or the evidence based chiropractor community is that it's not always controlled research in the wild. We're taking
Right.
care of people who
Exactly.
have organic things going on.
Yes.
And so if I can report back to you and say the neck care changed this much, this percentage with this type of people, but the research that you pull up that isn't necessarily similar, I think it's valuable, and it's how we move the needle a little bit. And that's something that you're also doing as well. Talk a little bit about you're doing some online education for practitioners as well, right?
Yes. So when did I start? In COVID, I started to offer education for clinicians on concussion. And at first, I've always actually separated into the phenotypes because it's so great
Mm-hmm.
for education. And now I offer some smaller courses that are focused, let's say, on cervicogenic, on ocular motor. And then every once in a while, I'll do a bigger one. So I was just in Calgary for 2 days and teaching clinicians in person, which is so fun. Um, and of course, because I'm an osteo, I draw a lot of osteos, but I get to sprinkle kins like me. I love kins too, and kinesiologists.
Mm-hmm.
I don't know if I've had a chiro learn from me, but it's because Cameron has them all.
Cameron and Dr. Chung, they all have them all.
That's okay. There's enough knowledge that needs to get out there that
Yeah.
there's room for all of us to help spread the word.
Uh-huh.
And it was actually fascinating this last weekend because, my approach is there's manual therapy in it, but there's so much more. And everyone
Mm-hmm.
in the room, it was their first concussion related course. So I definitely just blew their socks off. I was
Yeah.
making them doing things that are second nature to us, right?
Mm-hmm.
Tandem gait and cerebellar exam,
Mm-hmm.
looking at the eyes. And it was fun. It was
That's
fun.
awesome.
Yeah.
In the show notes down here, you'll find some of the references and resources to be able to get involved with that. But I think let's go ahead and wrap it up. Melissa, thank you so much for coming on. Do you have any words of encouragement or hope or anything final that you'd like to say?
Absolutely. So definitely always have hope about recovery. And you can always move the needle a little bit and
Mm-hmm.
then maybe a little bit more and a little bit more.
Mm-hmm.
So I think it can be challenging if you think of a huge change, like how am I ever going to run a, 10-minute mile or whatever a good mile is again.
Mm-hmm.
But you know what? First, you're going to walk conversation pace. Then you're going to walk faster. Then maybe you'll
Mm-hmm.
jog. So take it little by little. I want to say that. And also celebrate your wins. When you start to focus on the wins, that is going to build momentum.
Mm-hmm.
Right? What we focus on, we amplify. I think there's a proper saying for that, but
Nah, you did it.
yeah. And
People will quote you from now on.
right.
Yeah.
And that's it. Keep your chin up and you'll get
Mm-hmm.
there.
Yeah, life is often more often than not a journey, and healing is no exception to that.
Yeah.
So if anybody is listening to this, please reach out to Melissa. She's always a great resource on all of her platforms. Find her education online and start the conversation. We're never going to really move the needle until more people understand at least just the basics. So thank you guys for listening. Melissa, thank you for coming on.
Thanks for having
I'm
me.
grateful for all that you do for concussion patients and for people who are experiencing some of this. Yeah, I hope you guys enjoyed it. Please share it and subscribe to our channels.
Help spread the knowledge. Like you're helping people so much as well.
Absolutely. Education is empowerment, and empowerment is where the majority of our resources and the majority of where our life kind of starts to take off. Knowledge is power,
Absolutely.
Thanks so much, guys. Melissa, thank you again.
My pleasure.